Hydrocephalus. Hydro means water and cephalus refers to head. It is a disorder in which the cerebroventricular system contains excess amount of cerebrospinal fluid and is dilated because of the increased pressure. In normal physiology, the CSF is produced in the choroid plexus that are located in the cerebral ventricles, circulates through the ventricular system, and is absorbed into the systemic circulation. Choroid plexus consists of villous folds that are lined by the epithelium with a central core of a highly vascularized connective tissue. It produces CSF by active secretion and diffusion. The production rate of adults is approximately 20 mL per hour and a turnover of 3 to 4 times per day, but is less in newborns and children. The volume in infants is 50 milliliters and 150 ml in adults, and in these adults 25% is within the ventricular system. What is the ventricular system? Ventricular system is comprised of lateral ventricles that are connected to the foramen of Monro to the third ventricle. Then the third ventricle is connected to the fourth ventricle by the aqueduct of Sylvius. The three exits for the fourth ventricle, the paired lateral foramina of Lucia and the midline foramen of Magendie. This leads to a system of interconnecting and focally enlarged areas of the subarachnoid space known as cisterns. The cisterns in the posterior fossa connect to the subarachnoid space over the cerebral convexities through pathways that cross the tentorium. Then the basal cisterns connect the spinal cord and intracranial subarachnoid spaces. Stimulation of the adrenergic system diminishes CSF production, whereas the excitation of the cholinergic nerves may double the normal cerebrospinal fluid production rate. CSF absorption is not an energy-dependent process. Therefore, after formation, CSF exits the ventricular system. There is a brain pumping action that ejects the CSF and causes a net downward flow, causing a pulsatile to and fro motion of the CSF within the lateral ventricles. Then the cerebrospinal fluid is absorbed via arachnoid villi into the venous channels of the sagittal sinus, and some of it is absorbed also across the ependymal lining of the ventricles and from the spinal subarachnoid space. This is the normal physiology of CSF production and absorption. In hydrocephalus, there is an imbalance in production and absorption of CSF. Principal mechanism is deficient absorption from the mechanical or functional obstruction to the flow of cerebrospinal fluid, causing excess volume of cerebrospinal fluid, and this increases the ventricular pressure. CSF production continues, resulting in extreme elevation of intracranial pressure that preclude neurologic function and survival. The frontal and occipital horns of the lateral ventricles are the ones which enlarge first. Then there are three mechanisms of imbalance of the CSF formation and absorption, namely obstruction of the CSF pathway, impaired venous absorption, or overcirculation of cerebrospinal fluid. The disorder that results from obstruction of the ventricle system, whereby the CSF cannot travel freely from the start to the finish, is known as obstructive or non-communicating hydrocephalus. And in communicating hydrocephalus, it occurs when the subarachnoid pathways are blocked, whereby the CSF pathway is open from the start to the finish. Therefore, it is referred to as communicating hydrocephalus or non-obstructive hydrocephalus. The compensatory mechanism for this increased CSF volume is spreading of the cranial sutures. What are the causes of this hydrocephalus? It can either be congenital or acquired causes. In congenital causes, we have primarily aqueductal stenosis, Baker-Adams syndrome, that is the X-linked hydrocephalus, secondary aqueductal stenosis, anatomical malformations, Chiari malformations, meningomyelocele, encephalocele, or inherited metabolic diseases, or agenesis of the foramen of Monro. In acquired causes, we have infections like meningitis, post-hemorrhagic, mass lesions or tumors in the brain, then increased venous sinus pressure, together with an iatrogenic or hypervitaminosis. The clinical features of hydrocephalus in infants are resulting from an increased intracranial pressure and the dilatation of the ventricles, and they are non-specific and independent of the etiology. They involve an unusually large head and a rapid increase in the size of the head. Bulging anterior fontanelle, there is sleepiness, irritability, seizures, sunsetting eyes like you can see in this image, developmental delays. The clinical features in an older children and adults are a headache that is followed by vomiting and occurs mainly in the morning, nausea, blurred or double vision, sunsetting eyes, problems with balance, coordination and gait, sluggishness or lack of energy, slow development or loss of development. There is memory loss, urinary incontinence, irritability, and change in personality. When you conduct a physical examination, you realize there is a distortion of the brainstem, resulting in changes in vital signs. There is excessive head growth and ventricular dilatation. The anterior fontanelle will be distended or bulging. Frontal bossing. There is the scalp veins will appear dilated and prominent. Extraocular muscle paresis that will lead to diplopia. Pressure on the midbrain results in the impairment of the upward gaze, causing sunsetting eyes. And this is because of the appearance of the sclera that's visible above the iris. Fundoscopic examination will reveal papilledema. Spasticity of the extremities, especially the legs, will be present. Head circumference will increase in children, and these children will have an abnormally big head. When you conduct a McCune sign, you will hear a crackpot sound. The diagnosis of hydrocephalus is suspected in an infant whose head circumference is enlarged at birth or when a serial measurement crosses the growth curves. Antenatal ultrasonography can be used in diagnosing it before birth. Hydrocephalus should be considered in children with severe headache and other features that are suggestive of increased intracranial pressure. And it is confirmed by neuroimaging. In older infants and children, a CT scan or MRI should be performed. Neuroimaging studies will also detect associated central nervous system malformations or tumors. Then the site of obstructed CSF flow may be suggested by the pattern of ventricular dilatation. A lumbar puncture should be performed and the CSF should be examined if an infection causing adhesive arachnoiditis or epididymitis is suspected. But this lumbar puncture is contraindicated if the patient has evidence of a space-occupying lesion because of the risk of cerebral herniation. The most effective treatment is surgical drainage, but does not cure the hydrocephaly. This one is used to treat the symptoms. A mechanical shunt system will be placed that involves a placement of catheter into one of the lateral ventricles, mostly the right ventricle. Then the catheter is connected to a one-way valve system that opens when the pressure in the ventricle exceeds a certain value. The ventricular atrial or ventricular peritoneal, most commonly used, is the ventricular peritoneal. Endoscopic third ventriculostomy. This one is performed and made to connect the third ventricle to the subarachnoid space. And some medical treatment may be used, such as diuretics, fibrinolysis, and pseudolumbar punctures, but they are not effective like a surgical drainage. The diuretics in this case are furosemide, as acetazolamide decreases CSF production. The complications that may arise from hydrocephaly include the neurological damage such as a decreased function, movement or sensation, a blockage or kinking of the shunt tubing, and an infection at the site of the shunt can occur in some cases. Thank you, and don't forget to subscribe to our channel. It's easy made.